I'm gonna just ask everybody to join so that we might as well combine all the questions. I guess I'm sure that diet and fiber is probably, we're gonna talk about fiber, is probably always a super approach to it. I think Julia will agree with that. Let me ask you a quick question. Somebody asked about metronidazole. A cat that is only on metronidazole, would that also be a FMT, would be your approach?
Who are you asking to?
To you, Fabio, since everybody's still joining us.
Absolutely, absolutely. And we talked about this, Jan. We now, there's emerging data, and hopefully you will show it to us very soon, is that metronidazole in cats, it doesn't cause effects very different from what we saw from amoxiclavulanate and clindamycin. And so, yes, even in cats that have received metronidazole, I would think, especially young cats, FMT might be a very good option, treatment option.
Mm-hmm. Do you think, I mean, I think you showed the data a little bit, but Jamie showed it, can actually the microbiome restore itself, or will it? I mean, it will, but how long does it take after antibiotics if you don't do anything?
Okay, there are there is some variation, but usually, I mean, you know much more than me. By the end of a short course of antibiotic, if the microbiota is starting from a point of health, it won't take very long for the microbiota to return to health. But if the antibiotic is given over time, or if there are some concurrent risk factors or stressors, like I said, or imagine a cat with a diseased microbiome already, then we can see that sometimes the effects are quite lasting. This is my experience in dogs, but also in cats. And Lupin was a perfect demonstration.
There's a question. Do we have any evidence that a dysbiosis below 0 is a reasonable target to achieve?
I'm going to touch on what I just showed at the end. I think the target will depend on really what we are treating. So where the dysbiosis comes from. And so a dysbiosis index below 0 might be a good target, but if it's not associated with clinical remission, obviously may lose power, but it might be unrealistic in a cat with severe chronic GI disease. It might be very difficult to achieve. And in that case, clinical improvement in a multimodal strategy, it's perfectly fine from my point of view. I don't know what the others.
I guess the question was more or less, do we know that a normal dysbiosis index is associated with health? Let's put it this way. I think that's what I understand.
No, I mean,
is it reasonable to have a healthy cat that has an increased dysbiosis index or dysbiosis? That's probably the question.
That's the point. So if we find a healthy cat with abnormal dysbiosis index, are we sure that cat is actually healthy, or is it subclinical dysbiotic cat? And that's my interpretation. And we have the lack of following sometimes cases over time, and we see how sudden a normal cat will develop chronic refractory GI signs. So those healthy cats with DI above 0 could be preclinical patients.
Yeah, let me maybe my thought on it, that we have really plenty of data now to say it is clearly not a normal microbiome. But the dysbiosis index, what it says, it's a shift in the microbiome. So it's not a specific marker, but if it shifted, there's something going on. It's definitely not what the huge range of normal is. And then we had to put this in the clinical track and so on. And I guess the question would be, if you don't do anything, an animal that is antibiotic-induced long-term dysbiosis shows no clinical signs, should we do anything? I don't think we know yet the question, but theoretically, it's probably not a good thing to be dysbiotic. Let's put it this way. But solving the problem right away, we don't know yet if it makes sense, but I think that's probably the question. Great. A lot of questions came about donors and how we do it, because I think there's still confusion. Again, I think we touched a little bit still, I think, about what dysbiosis means. Again, just to summarize briefly before we go on the donor is, dysbiosis mostly means it's a state of something, and then clinically we need to put in what is the most likely explanation that it has it, correct? That's where we'd see it. One question came, Julia, not for FMT and fiber, any contraindications? No, would it be actually even good thing? Probably, correct?
Yeah.
Okay, perfect. I think we're changing our approaches. That's multimodal, everything is what puts in the right direction is better than in the wrong direction, correct? In Europe, people ask, in Europe, and many tests were mentioned, but how they are available to practitioners, and if they're not available to practitioners, how do you actually approach that? Fabio, maybe you or Julia, since you're in Europe, and then Janessa, maybe like afterwards for donor screening, you could afterwards.
I'll let Julia first.
So what tests are meant? I mean, because I'm not in the clinical practice, so I know that the dysbiosis index is available, but I'm not the perfect person to answer this question, actually.
Okay, I can actually, if you may just rephrase the question, yeah, so to make sure that
a lot of speakers have discussed advanced diagnostics and treatments that aren't available to general practitioners. What advice do you have for general practitioners wanting to practice better microbiome science? And I think the test we mentioned is very bile acids, which, yes, it's not available anywhere, but also in humans, it's not available yet. And then dysbiosis index, but it's available in some countries in Europe. Yes,
so luckily in Europe, through I mean, we could all, of course, ship our samples over to you, but it's not that, as Jan knows, it's not so easy from Italy. So Italians are very difficult people sometimes. But unfortunately now, through a commercial lab, IDEX, I'm gonna say, we can actually request dysbiosis index in our patients. And since then, we've been using it quite a lot. And we are, if I may say, Jan, we are placing dysbiosis index in the diagnostic approach to cats and dogs with GI signs. So we learn, the more we use it, the more we learn on what to make of dysbiosis index. And I liked the data from Dr. Sung, where you could actually see that perhaps dysbiosis index might actually serve as an early marker of GI disease much earlier, for example, than hypocobalaminemia or hypopholetemia. And so we need to start thinking in these terms as well. So,
but maybe the segue to the donor screening, because obviously it's not going to be available anywhere, even in some countries themselves. I know there's also not enteropathogen screening. It's also difficult to really have classical pathogen screening. So what would be the recommendation, Janessa?
Yeah, so we included on the slides today are kind of some starting points for how you would test for those. Obviously, you might not even have those available to you. I think if you don't have those available to you, but your donor meets the rest of the criteria, I think it's an opportunity to talk with the owner about what the potential risks are. I don't think that it completely precludes you from doing the procedure, but I think just making sure that the owner understands that you are limited and you're not going to be able to screen for all the enteropathogens. Or, for example, in the US right now, screening for antimicrobial resistant organisms is really based at universities only, and it's not easy to get commercial access to that test. So donors in the US are likely not going to be able to have that done right now. And so I think, again, it's this thought of this tiered approach and making sure that you're having open and honest, communication with the owners about how you screen your donors. And that's really going to be reflected in the guidelines of this is the recommended, but we understand that that's not always feasible and practical given your current situation. And so we'll have options within that as well.
Mm-hmm. And so that pretty much brings the next step. I think what I get, and I mean, I'm on the consortium, Fabio's in the consortium, Janessa, is that FMT is considered pretty safe, correct?
Yeah, I definitely consider it to be safe and well tolerated. I mean, there are all of us have experienced some animals that have transient signs, but I think for the most part, I would recommend it. And even in, I get a lot of questions about immunocompromised patients, of whether we feel comfortable. And when we look at collectively all the dogs and cats who have been treated that are on immunosuppressives or that do have a disease resulting in immunosuppression like parvovirus, I feel very comfortable recommending it. And the way that I explain it to either practitioners they're asking me or even owners is that right now in that sick patient who's immunocompromised, they have an entire ecosystem of microbes that are there. And our goal is to try and shift it to a more healthy group of organisms, but they already have a population that's there. So now, it's always possible that, it could cause animals to have vomiting and diarrhea, and that, worsens their clinical picture. So those complications need to be discussed. But in general, I feel very comfortable recommending this even in the sickest of my patients.
Yesterday, we also heard about dogs with AHDS, so acute diarrhea syndrome. There was no side effects, I think. Yeah, so there's probably not really a contraindication, correct? That was the question that you would on top of your head. Maybe also important to add in human medicine, yes, there were some cases, but those were cases in an extreme immunocompromised situation, correct? Those were patients who participated in a study about bone marrow transplantation, stem cell, and so on. I think that was an extreme case, I believe. So it's important to highlight.
Yeah, and my lab group is starting to look at this a little bit more about, if you have donors that are positive, do those organisms actually engraft, and how long do they persist? And also we have to remember that even the patient that we're giving an FMT to may have some, and likely may have some antimicrobial resistant organisms within their own microbiome. And I don't think any of us in the consortium are testing our recipients before they get an FMT for that. And so I think, we have to remember that these organisms can be present in both the recipient and the donor as well. I'm not saying that we shouldn't screen for it. And I think as it becomes more clinically available, I think, we should definitely include it in our evaluation. But for some people, that's just not going to be possible. And we talk to our owners about that. I'm not able to screen for this. Is it a possibility? Yes, but I think it's very, very low risk.
Mm-hmm. There are quite a few questions again about donor screening, but I think they came in while you were talking, so I think they're answered. Okay. Just again, the safety issue is, again, just to highlight it, is that there's no potential danger. Is there any potential danger to performing FMT when in colitis or after taking endoscopic biopsies?
I have no concerns at any of those for causing, to have it be contraindicated. In fact, I think that those currently in the literature, the acute colitis part, we have enough evidence that's high level that we should be using it, and that's safe, well tolerated. So yeah. And as far as giving it after an endoscopic procedure, same thing. The gut's still full of microbes, and you're adding some more to it, but they're all still there. So I don't have any concerns about like the integrity of the mucosa after biopsy or anything like that for worry. And again, endoscopic FMT is a common delivery in humans and is used in a variety of different disease states, including severely immunocompromised. So I think, even if we don't have a ton of safety data on the veterinary side, we have a lot on the human side to feel very comfortable with that recommendation as well.
Jan, if I may add, I don't know whether you can hear me, on the safety side of things, just to show how safe the procedure is. In people, they are now using it to control chemotherapy-associated GI signs, and we are, as you know, we talked about this, we are actually thinking of doing that. So these are potentially patients that will develop severe myelosuppression because of chemotherapy, and so I think it's a statement about the safety. So don't worry. I mean, speak to the owner. Don't worry.
Yeah. And same thing about the dosing and so on, about oral capsules. I think we discussed this already. We don't yet know what is better, but I guess the assumption is there's so much bacteria that even probably if something doesn't go to the stomach, it's still probably plenty. And I think we have some cases where we know we can see the improvement in the microbiome, improvement in clinical signs after oral capsules. So I think that's all coming, correct? But I think, again, coming back to this notion is a lot of bacteria in 1 gram of feces.
Absolutely. And within the consortium, there are a lot of ongoing clinical trials in this space to look at dosing and different diseases and routes of administration. So I think we're going to, in the next even just couple of years, there's going to be a lot more evidence to base some of these recommendations on, which will be helpful. But absolutely, I agree that, you know, we don't know the optimal dose, but some is better than none. One thing I would say is if you have a patient where you've tried capsular FMT and it's not working, I don't think that it's wrong to try an enema instead to get it to the site, because then you take out the route of delivery as a potential. And so if you did go for trying to give it orally and you're not seeing great clinical responses and clinical remission, I think trying a repeat treatment with an enema is very reasonable. We have some studies that are ongoing where we're giving an enema as an induction dose, and then we follow it with oral capsules. So I think there's a lot of room to look at different dosing strategies to try and get maximum benefit.
Mm-hmm. Perfect. Now I lost my question because we talked about the low budget screening. Diets. Julia, I mean, I know that you don't do much FMT, but I know that you have some of your clients have been a combination of FMT plus dietary approaches, correct? Would you consider, from your thought, would it make sense anything to think about the diet of the donor itself, or?
Well, if you have a dog, a receiver who has a potential food allergy, it's good to give the same diet to the donor dog. I think
okay.
This would be my only concern, actually.
Mm-hmm.
Yeah.
Okay, but on the other side, you mentioned before that you don't think the food allergy is that common. Is that correct?
No.
So that
I mean, we also have data that support this, that you have about 1% of the population, or let's say even if it's less than 10%, it's low enough to look for other causes than to go for the allergy direction. Okay. Yeah.
Maybe just one question, because this came up yesterday, the DI and diets. Just maybe I want to clarify that it is really validated against the huge range of normal, against chronic GI disease or other dysbiosis. So most dietary changes, they're still going to be within the normal range of the DI. That means diet can have an impact on the index on microbiota, but again, it's still within the normal range, if that makes sense. So an increase over 2 is really, really, or a cat in ones, it's definitely not diet induced. Okay, so they just want to highlight that. And it's also the DI is species specific, because they're different bacterial taxa. And this actually a question comes up nicely. Fusobacteria is an interesting topic, because in Fusobacteria in humans is actually a pathogen, correct? At least there's some associations. In dogs, it's considered to be a beneficial bacterium. And in cats, it's not really so there, but there is some data that some Fusobacteria were attached, like in humans, to a little bit. So that's coming from. But again, at the moment, there's still probably much to learn in microbiome, targeting specific species that may be associated with them, but those are probably more rare than we think. At least that's our current knowledge. I know you would agree, Janessa, to that.
Yeah, I mean, I think that's you know, there's a commercially available phage product right now that's on the market and in the US, and I would say, you know, we don't have the clinical trials to really look at and evaluate clinically what a difference that makes. And so I think right now, you know, I get asked a lot of questions about integrating that phage therapy in, and I don't think as a clinician I have enough evidence to make that recommendation. In theory, absolutely, and there are many biotech companies on the human side that are looking to do this and design or microbiome style by using phage cocktails. And so not to say that we won't get there in veterinary medicine, where, you know, I could see futuristically we use the DI index, we can base our, you know, treatments based on what that looks like in a very targeted multimodal approach, but we're not there yet. So I think we have the possibility to get there. And I think that there are more and more groups that are working in this space, which will help to accelerate this area quickly for veterinary medicine, which is, I think, exactly what we need.
Yeah, maybe just my brief comment, my side, because I also get asked a lot. And bacteriophages, and we work with somebody here on campus who is an expert in bacteriophages. And even they say it is a great tool, but very, very, very specific. So bacteriophages are so not even species specific, they're actually strain specific.
Yeah.
So you would actually, even for E. coli, you would have to really target the right strain. And that's why they don't really work in a broad spectrum. The great approach would be, for example, if you have a very antimicrobial resistant bacterium in a wound or something like that, and you cannot get rid of it, that would be the approach where the bacteriophages maybe work. But from a broad perspective, it's very difficult to target, like we're going to reduce some bacteria or something. So that's.
And I have used phage therapy that was patient-derived for a highly resistant UTI in a very investigational manner, but it was a last resort for that patient. So absolutely, I think, we just need to be cautious as we start to look at these new therapeutics and figuring out how to put them into practice clinically. And so right now, for me, the phage side, I don't think as a clinician, I have enough evidence to recommend it. Fabio, what do you think? Do you recommend it for your patients at this stage?
No, I'm on your side on this. There's no data at the moment for us to recommend it.
Mm-hmm. Jamie, quick question again to the diet and donor. Your donor cat was on what kind of diet?
They were all on a commercial laboratory animal diet.
Again, the question came up again. So in your case, you didn't really see any side effects or clear side effects with the actual FMT itself, correct?
Yes, no, they had transient diarrhea like the following 24 hours following the procedure, but they had we didn't encounter any events.
But maybe the only difference important to highlight, and we know that's the cause, but you actually mix with glycerol, correct?
Yes.
Okay, and glycerol may potentially be one reason that you have this one bout of diarrhea, versus I think glycerol, and some people don't use glycerol, and that's it is. But again, it's possible, I think, but that's important to also highlight. Just one quick question again: the confusion of dysbiosis and GI disease, one or the other. So the question is, every cat have GI dysbiosis? Every dog has dysbiosis? Is it possible to have chronic enteropathy without dysbiosis? And maybe just to start the discussion would be, how do we find chronic enteropathy? Is chronic enteropathy really one disease? Is food responsive one disease, or is there a huge range? So maybe Julia, what do you think for the food responsive side?
Well, I think that the whole food responsive part is not fully, how do you say, I'm missing the word.
Not well characterized.
Yeah, exactly. And I think it has a lot of potential to look on this side, because, well, at least what I see, that lots of my patients who are referred with a chronic enteropathy will respond to different dietary management once you understand the underlying problem. The case of Anton we showed, it's a wonderful case, but you have also these cases in smaller shapes and you have to find them. So this is a little bit more tricky, but it will still work on different aspects of diet. And I think it would be good to, for some cases, maybe to work with a nutritionist who can find these little differences in diets and maybe give a direction on what to try, except FMTs and all these other measures you can use.
So it's actually possible that animals with chronic diarrhea don't even have GI disease. I mean, definition was GI disease, but if they don't have changes, just the wrong diets, that's probably a substantial.
Yes, definitely. I don't know if this will turn into a chronic enteropathy at one point, but definitely there are patients like this. Yeah. Okay.
So we have the last rounds. Fabio, what's your thought about chronic enteropathy?
No, I'm definitely agree with Julia on the possibility of negative impact of diets, like on the GI tract and GI signs. So it's perfectly possible to have dogs or cats with GI signs that are not dysbiotic, but they only eat a poor diet. My problem is with chronic enteropathy. I now know, I think this is my conviction, is that we we need to rewrite the definition of chronic enteropathy, because the previous definition, I think it's not necessarily correct. And we now know that the majority of patients don't need and won't have endoscopy, so we won't even know histologically, histopathologically how the GI tract looks like, and so there's a huge overlap, and so I don't think it's correct to talk about chronic enteropathy in patients that only have chronic GI signs, because there's a huge overlap there. So we talked about this the other day, and you know that I'm quite passionate about trying to rewrite the diagnostic approach definitions, because at the moment I think there's a big confusion. That's probably why some chronic enteropathy patients may have a normal dysbiosis index. I wonder whether these are true chronic inflammatory enteropathies or not.
Okay, Janice and Jamie, just one. Do you have any last comments?
Yeah,
before we
I
wrap
mean,
up?
I agree that we need to reconvene on what the categorizations are, because chronic enteropathy to me is the big umbrella term, and then we have all these subsets underneath. I think from, I'm internal medicine specialist in the US, and I think one of the things that GPs can help in this space is to really do the initial diagnostics that you have available to you to rule out extra GI signs, to rule out parasitic infectious causes of diarrhea. And when you're stuck in that non-infectious category, diet has to be your first step, right? And I think there's so much power in that for such a large percentage of patients. And what that diet means is going to be patient specific, and we don't have a diagnostic right now to tell us that. So whether that's going to be a hydrolyzed or a high fiber or highly digestible, or you name a combination, is going to be patient specific. But I think as a GP, you have a lot of power to make a big difference in a lot of animals' lives that have chronic enteropathy without needing to do advanced diagnostics.
Great. Jamie, do you have some, since you are now fresh in specialty practice?
No, I mean, Dr. Winston said basically everything that, she made a really good point that I think diet has to be a first. And that is something that is, easily done out in general practice. And I think there is a lot more kind of on the horizon in terms of, what does idiopathic chronic enteropathy actually means. So yeah, it's a space to kind of keep an eye out for in terms of, the FMT and studies in dogs and cats. But yeah,
great. Well, thank you. I think we need to wrap up. So thank you, everybody. It was great discussions again, and I'll give Natalia the last words.